good morning, good afternoon, and good evening, everybody, and welcome to another week of the Global Cafe. My name is Elizabeth Lewis, and I'm a Senior Project and Policy Coordinator here with the IFA, and I'm very excited to be introducing you all to Dr. Christine Jensen to discuss person-centered and family-centered training approaches for caregivers. Christy is a Director of Health Service Research with the Riverside Martha W. Goodson Center. The center is a part of a larger health system in East Virginia. She's faculty affiliate in the Department of Gerontology at VCU. She obtained her PhD in Human Development and Family Studies with a specialty in Adult Development and Aging from the University of Delaware in 2002. She's active with the Gerontological Society of America and the Southern Gerontological Society, past president, and the Virginia Center on Aging and the Lindsay Institute for Innovations in Caregiving. Jensen is a master trainer with the Rosalind Carter Institute for Caregivers and was named the 2015 Applied Gerontologist of the Year by the Southern Gerontological Society. Christy has 2 book chapters and 17 published articles, most in the field of family and dementia care, workforce training, and community needs assessment. So we're very honored to have Dr. Kristen here with us today. Good morning, Dr. Kristen.
Good morning.
And I'm very much looking forward to an excellent conversation today. So just to get us started, could you give us a bit more information about your background and what led to your passion in gerontology, caregiving, and healthcare training more generally?
Sure. And thanks for having me and welcome to everybody today. I appreciate you all taking time. I guess I could even think back to my undergraduate college program and a professor who was really passionate about gerontology. And when you have someone who really speaks so highly and so comfortably, well educated in gerontology, it really that's what sparked my interest, I think. And then I was able to continue to find similar mentors
Mm.
in the graduate programs that I was in. So also in a part of working through my graduate work, I came across a particular caregiver program called Caring for You, Caring for Me that the Rosalind Carter Institute for Caregivers had created. And so that was another piece that really kind of sparked my interest in this area. And I can speak a little bit more about that caregiver program and how it really fostered some of the other work that we're doing now. That program has been around for more than 35 years, which is pretty remarkable, thinking that, the term caregiving is really still kind of coming to the scene now. So that opportunity to learn more about that particular program allowed me to go to Georgia a number of times and work with our former First Lady, Mrs. Carter. So that was a real honor and something that even as an undergrad in college and thinking about if this is a field I want to work in, wouldn't have imagined it would have kind of had those important pathways.
Wow, no, that's amazing, and I'm sure that was such an amazing opportunity for you as well at the time. That's
It
really lovely to hear
it
about.
was, it was. And I think we all probably have personal stories too. So
Mm,
my grandmother lived to 94, had other relatives that lived into their 90s, and then watching my family members help in caring for those individuals when I was younger. So I think many of us have a personal story that pulls us into our interest in aging.
hmm. Yeah, thank you for sharing that. And I guess it sort of also leads into my next question of if you could define person-centered and family-centered approaches to caregivers or to caregiving and maybe more in particular caregiver training.
Right. Okay. Okay. Thank you. So I think person-centered has been a concept that's been around for a while, 20 plus years, kind of that idea that if we're going to deliver person-centered care, or in this case, I'm referring to the training, that we really are, we're genuine about our intent, that it is accessible and it is meaningful. It's structured in a way that those individuals who need that care or could benefit from that training are really kept front and center. And I'll be able to give you a few examples of that as we talk this morning, particularly with a micro-learning series of lessons that we've developed. So I think the family-centered concept is a little bit more recent in terms of, really looking at the individual who may need care or support if that's the older adult, but what's the family unit? And it's likely that the family unit needs something as a whole in terms of the care and in terms of the training. And that might not be the same for each member in the family. So again, it's not a case by case basis per se, but it really is being very intent in understanding who needs the care, or in this case, the training, and how do we want to deliver that. I think you still can keep all those things in mind and package a program that can be delivered in multiple different ways and meet the needs of different individuals. So an example is this micro learning series that we've created, and I think there are some resources that you're going to be able to provide as a part of this webinar. So I can speak a little bit more about that now, or we can
Sure,
wait
yeah.
as we.
Yeah.
Okay. So microlearning is not our concept here within our healthcare system. It has been around kind of in industry, even in business, this idea that can you deliver training in real small bursts in less
Mhm.
than 10 minutes and be effective? Because we've all experienced training where we might think it's a good thing if it's only an hour, but often we're in trainings, especially if we're trying to get certified in something that's hours long, it's several days
Mhm.
long. And working where I do in a healthcare system, I don't have the luxury of training our colleagues that are direct care staff for that amount of time. They just
Mhm.
cannot leave their care responsibilities
Right.
in the professional setting to do that. And so when we learned about microlearning maybe 8 years or so ago, we realized that was something that we wanted to try here within our own healthcare system and within the Commonwealth of Virginia with training nursing home staff. So our first exposure to microlearning was not with family caregivers, but we now have brought it to family caregivers, and I can speak a little bit more about that too. But the our initial exposure was to take trainings that did last several days and break them up into these smaller bursts or nuggets where it's really one concept being passed along at a time. And these are these are made available online, but they're, interestingly enough, highly interactive. So they often have actors or real individuals talking
Cool.
about or demonstrating their experiences, demonstrating a skill that is needed in order to care for an older individual. And then what we've also found is pretty successful with the micro learning lessons. With the first ones that we did for nursing home staff, we did 52 lessons. And so the intent was they
Wow.
would get one a week for a year. And indeed, wow, I think everybody thought, how are we going to get through this? But we also did a lot of prompts. So it was like, good
Mm.
morning, it's Monday. It's time for your next micro learning lesson on this particular topic. And so folks got into a routine,
Mhm.
and that worked quite well. And we actually trained hundreds of nursing home staff across about 10 different nursing homes here in Virginia with that. And we would consider that person centered
Okay.
for the trainee, for the staff. And they could do it on their phone. They could do it at a workstation. They could do it on their laptop, a computer at home.
Mhm.
And they didn't have to do it the minute that the reminder came in. There was a lot of bit of flexibility during the week as to when they could complete that. And then there were quiz questions that kind of went along just to tap into that one or two pieces of information we were trying to pass along. Did that get conveyed? So since then, we have built out a whole series of microlearning lessons, most of which we post through our health system on our YouTube channel. And so those are funded through a variety of sources, but are made free and in the public domain.
That's awesome.
And so the most recent one is 10 lessons for family caregivers of individuals living with memory loss. And it's based on the initial program I spoke of Mrs. Carter, the Caring for You, Caring for Me. We received permission, that's a 10-hour program, to modify it to a 10 lesson program that is about 1 hour in total and is called Caring for You, Mind, Body, and Soul. So we received federal funding here to be able to put that program in place. And even 10 lessons once a week can sound like a lot for a family caregiver. So what we've
Right.
decided to do, in addition to putting it out on our YouTube channel, is to structure it in caregiver support groups. And
Mhm.
so it gives caregiver support groups and their facilitators some content that they can use however they wish. There's a lot of flexibility, and we provide a facilitator guide to go with it and how they might use these 10 lessons. Do you want to show a lesson during your group meeting and then discuss it? And we provide discussion questions, or maybe watch it before and come prepared to discuss it at the group.
Mhm.
And so those are just some examples, I think, that are person-centered in your training, because you're trying to be
Mhm.
flexible enough and accessible enough with the
Mhm.
content, and in this case, brief enough that it isn't overwhelming.
Right. No, thank you so much for explaining all that. That's a very innovative idea and certainly helps proliferate training opportunities. I guess what I'm curious is if you could expand a bit more on what sort of the typical barriers are for more, I guess, traditional forms of training opportunities, and even what some potential access barriers can be with the micro learning that you have as well.
Okay, yeah, thank you. So I think well, some of the barriers to doing caregiver training aren't even with the training, it's with caregivers not even identifying with the term that we're
Mm,
using. So
mm,
we kind of have to back up and say,
mm.
okay, are we referring to you or recognizing you or identifying you in a way that's comfortable to you?
Right.
And so that's probably an entire another session or debate about that. But we hear folks refer to carer and care partner,
Mhm,
and all of those are fine. I think it really is up to the individual as to what they feel comfortable with, but we do encourage them to kind of embrace a label, because it does help set some identity and some recognition. So I think that's first is, who are we trying to target with the training? And if it's family
mhm.
caregivers, do they know that that's them when we're trying to,
Right.
these are the roles you're fulfilling that are so valuable to
Mm,
your loved one and our community and our society. How can we then provide you the kind of education and training that might be beneficial to you?
mhm,
So you
mhm.
may need to remind me. I know there were several parts to your question there. So that's kind of more
Mhm.
about the identity of the caregiver and some of the barriers we have there.
Yeah, and maybe I have a couple questions now, so I'm trying to see what makes sense first. But I guess maybe if you could first expand on what some potential barriers that persist in the micro learning modules, or some considerations that you've made in creating them to ensure that they are accessible to all populations or as many as you can.
And I think one of the barriers we had before we created microlearning that I mentioned earlier was just the length of training. And
Mhm.
there are still trainings that are offered. There's a training through the Rosalind Carter Institute that we offer now that's called Dealing with Dementia that's 4 hours. And that's the way it's packaged. So, and we have good turnout and good success with that program. So, um, but I think having a menu of options, and that's
Yeah.
what microlearning gives us the flexibility to do. So I think some of those barriers we tried to work around or address in terms of just caregivers not being able to get away from their home
Mhm.
to leave their loved one to come to a program. Could it be on demand and accessible right at their phone or
Mhm.
on their computer or tablet? But even with that, you're right, there are some barriers there. We have individuals that live in very rural settings, and so sometimes the Wi-Fi connection or their broadband is not reliable.
Mhm.
And we have individuals who are just not very comfortable with their phone or computer in terms of delivering training or receiving it like that. And
Right.
so that's why we kind of try to create what might be a compromise with a caregiver support group. If you are able to participate in a support group, either in person, face to face, or a virtual group, then could we bring some of the lessons and incorporate them in that way so that you also get the exposure, but there's someone else, your facilitator, who's kind of responsible for walking you through it.
Mhm. Mhm. Yeah, thank you for expanding on that. And the other thing I want to loop back on that I found really interesting was the comment you made about the difficulty in even getting people to self-identify as caregivers. I guess I don't know if there is an answer or not, but how can we encourage more folks who we would maybe describe as caregivers to also self-identify as caregivers and to access the resources that are available to them?
Well, I wish there, like you, I wish there was an answer. So perhaps some of the folks on today can kind of
Yeah.
help us with that. It's something I've been grappling with, and others who are in the field of caregiving work have. And again, I think we sometimes are the guilty ones as researchers or
Mm,
advocates in that we have placed this label that isn't something that everyone can identify with.
mm,
And so I think we need to be careful and sensitive about that. Just because it's a label that makes sense for us as researchers,
mhm,
and we need that because we need to be able to kind of define, give an operational definition. What do I mean by a family caregiver? How long have they been
mhm,
providing care? Who are they providing care for? Where does that person live? What kinds of roles and responsibilities do they have? But regardless of the label, again, encouraging uh, individuals who are providing care to really, the role isn't easy. And so I think that's the other thing that we want to say is we recognize the challenges and we want you to it isn't always easy to embrace those challenges, but to be honest and open about them. and with other people. So I think as you start talking with other individuals, not just with researchers, but you're talking with your physician, for example, let them
Mhm.
know that you are providing care to another relative. That is one of your key roles, likely. In fact, it might supersede a number of other roles, even impacting your ability to be an employee in a
Mhm.
company. So, talking with others, is that a healthcare provider that you're sharing this with? I work in a healthcare system, and so I'm advocating with our physicians all the time. We have hundreds of physicians in our medical group. Ask your patients if they are providing care to another individual. That is really important for us to know. And then when we do know, it then is our responsibility to get them access to the resources that they need. I think speaking with your neighbors, with folks in your churches or religious organizations, your other family members, again, and just kind of being honest and open about this, regardless of kind of what title or label that we give it, I think is really where we can start kind of at the individual level.
Mhm.
And then as we offer more programs where we're using these terms, but again, not just saying, are you a caregiver? Would you like to come to a program like this? But really helping individuals identify that the benefits of the program or the value to them, which may not
Mhm.
meet the needs of everyone. I think that's another way. And I just think in being in this field for 20 plus years that the term caregiving has really it's kind of risen to this level of recognition that we haven't seen before, that as somebody in the field I'm grateful for. I'm grateful. We can talk in a little bit about this concept of kind of caregivers being invisible, and they may still feel that way. I was recently caring for my father-in-law and my mother, and I very much can relate to that kind of feeling of being in the background. But we have national organizations and international organizations, and we have the RAISE Act here within the U.S. There are a number of organizations that use the term caregiver in their title and are fully embracing it. And one of those, as I gave the example, 35 years and going at least, is the Rosalind Carter Institute for Caregivers. So I'm grateful for these kind of organizations that are just wanting to embrace all the experiences of caregivers and provide the programs and resources that might be of most benefit. But having said all that, it's still a
Mhm.
challenge, and we still have individuals who will say, like, "Don't call me a caregiver. I'm their spouse. That's my
Right.
label or that's my identity." And so we understand that, we appreciate that, but we say if there are programs that are geared for you, keep your eyes and ears open for those that
Mhm.
are caregiver specific, because they may be a benefit to you.
Thank you. Thank you for expanding on that. And maybe also to help any folks in the audience to help conceptualize where they fit into this puzzle. Could you also expand on sort of how the needs and experiences of caregivers differ on the basis of their age or their race, gender, family conditions, and socioeconomic structures? Could you expand a bit on how caregivers' experiences are not necessarily a monolith?
Indeed, indeed. And I think we also, as researchers, have a real responsibility to not assume it's a homogeneous.
Hmm.
I can't answer all the questions you've asked there, because you mentioned something about like socioeconomic status. There's a lot of different tiers to that, and there are a lot of my colleagues throughout the U.S. In particular who are looking at some of those areas. But I think my focus has been kind of in what is the connection or the relationship to the person that's providing care and receiving care. And
Okay.
so I've been looking particularly at, okay, is it the adult child providing care to their parent? Is it a niece providing to an aunt? Is it a grandparent grandchild relationship? Is it spouse to spouse? So or is it sibling and so and of course there are certain situations where their peers or their friends or their neighbors or their church members, and they're not related. So that's kind of been my focus: is, are there distinctions between those types of relationships? Do they live together?
Mm.
Many folks, are geographically separated. And so how is that care done? Especially if it's long distance. I
Mm.
think that's something that we try to consider. And then what is the condition that they're providing care for? So
Mm.
much of our work here in our center and in this healthcare system is focused around memory care. So if you were to ask me, what is the caregiving experience like for someone caring for a loved one with Parkinson's disease? Not really going to be my area. I
Mm.
could suppose there'd be some commonalities or some links to some of the other types of caregivers. But much of my work has been in providing support to those individuals who are receiving care, who have memory loss, or who have been
Mhm.
providing that care. And also, and we can speak about this a little bit later if there's interest, um, uh, the professional caregivers. So those folks who are not only not related to the individual, but they're being paid and likely have received training that this is their specific job role. And so that's where a lot of this crosses over with my colleagues who work here in our healthcare system and providing them the kind of training and support. So I'm not sure how well I answered that because you had a lot of different pieces in
Yeah.
there. It is complex, and there are cultural backgrounds to consider. And so it isn't, again, that's why when we try to create some of our training programs, or we refer folks to other caregiving programs, and the best practices for caregiving website, which is something you all might want to share through the Benjamin Rose Institute on Aging, lists all kinds of caregiver support programs that are evidence-based. So we're trying to create some and add to that menu. There are many others who are doing that. And so then I think it's up to us to help individuals who might benefit from these programs know which one to choose from. Because now we have a
Right.
menu, we don't want to overwhelm folks. So you can choose one that's, a few minutes long to one that's several days or month long,
Mhm.
and they have a different focus. So
Mhm.
the best practices for caregiving site through the Benjamin Rose Institute on Aging might be another resource.
Thank you, and we'll be sure to share that resource as well. I guess I'm curious if you're able to expand on either how the micro training itself uh, takes different approaches based on the family structure or more generally, but how, if you could speak to how sort of a training opportunity would tailor differently to, say, someone who identifies as a son or a daughter versus a neighbor or a partner or spouse, or sort of if you could expand what those approaches, how they would look different.
So I think that's partially in the language that we use. So
Mhm.
we do try to be sensitive that if we're going to develop a program that's for spousal caregivers, we're really clear about that. And
Mm,
this is who the target audience is, and this is the kind of terms that we're going to use to describe this relationship or this situation. Most of the time we don't do that, and we are more focused on what is the condition of the person that you might be caring for, and so is that someone who has memory loss in our case, most of our experience, but if, trying to make it flexible enough that the resources, the skills, the techniques that we're trying to pass along would be helpful to somebody who lives with the individual, who doesn't live with the individual and checks in on them occasionally. Again, kind of regardless of their relationship. So
mm,
so I think that's where having some flexibility in it. But again, backing up to, what's the language? Who are we trying to target? Um, Much of ours has been focused on family caregivers. And so we describe that, but we recognize that not everyone is connected in that way. And we're
mhm,
grateful for those individuals who step in when individuals don't have family or are estranged from their family, but there's a neighbor or a church member or someone else who is available to provide support to them. And then in terms of the training that we deliver that's micro learning for professional staff is, again, the most of them we are referring to as professional caregivers, but then we use language like, are you direct care? You're maybe at the bedside in the hospital setting or in a long-term care setting, assisted living or nursing home. Um, or are you not direct care, but you have some ancillary support to this individual? So you might be even in dining services, and you're still
okay.
engaging with these individuals. So in our healthcare system, some of this training that we're providing around memory care is mandatory, meaning it doesn't matter what role you hold in our healthcare system, you have an important place in this care, even if you are, as the environmental services and you're providing cleaning services. You
Mm,
are transportation and you're taking them out of their room for other testing.
mm,
Those are all extremely valuable and are all have opportunities to touch these patients that we serve. And so it's been a real interesting approach that our healthcare system is really dedicated to making sure that all of our team members have memory care training. Again, not just those you might typically think of, like our clinical direct care staff that are kind of right at the bedside.
No, that's really interesting. I wouldn't, my brain wouldn't have gone there of folks to include. So thank you for expanding on that. I just want to hop in the chat here and I see some questions coming in. So please do feel free to put your questions in the chat. We have a question from one of our cafe regulars, Shmuel, who is asking, how, according to your opinion, person-centered and family-centered training approaches can support improving well-being and development of professional skills amongst caregivers from poor and low socioeconomic groups of the population?
Yeah, great question. Do my best to answer that. We don't always gather economic information about the folks who
Yeah.
participate in these. So we don't always know, but we do try to be sensitive when we offer these programs that we're promoting them widely. It is a benefit to individuals who can't get out or don't have reliable transportation if they can participate in microlearning in their home, if they do have access to the equipment to connect. We have even received some grants that provided us with iPads that we could then deliver to individuals in their homes so they could
Okay.
participate. But we don't always ask about or know the status of individuals in terms of their socioeconomic status. But we do try to be sensitive about how we're reaching out. We, in the eastern part of Virginia, where we are here, it is there are a number of rural areas. And so we do try to be sensitive about, I think the most important thing, it's upsetting to me when I hear caregivers say, I had no idea that training was going on, or I didn't know
Mhm.
how to access it. And so it's really up to us to make sure that we are communicating clearly and promoting about these kinds of opportunities. And then I think the other thing that might be in that question is, what are we doing to evaluate the impact of these? How do we know they work? And why have we continued to create kind of these menus of micro learning lessons? And so we do evaluations, and often we are, as I mentioned earlier, because these are multi-series, it's not just coming and doing one and completing one evaluation, but you have as many as 52 lessons or 10 lessons. One of them we do for primary care providers is packaged as 5 lessons. So the evaluation is multi-pronged, and there's kind of a baseline on the front end, and then there are questions that are asked after each lesson, but only one or two, because we know that can be cumbersome, and then a more thorough evaluation on the back end of that. So the reason we like doing the questions at the end of each lesson, and we call those micro steps, are that we can kind of get a sense if one lesson might have resonated more with the target audience than another, what they learned, what their takeaways. And so with these micro steps, not only kind of quiz questions about what they learned about the key concept, but what micro step might they pledge to take in caring for this individual that they now have resources or tools or techniques about because they learned about that in this particular lesson.
Thank you so much for expanding on that. And I see another question from an audience member named Monique. If you are here and you want to answer or ask your question yourself, you're welcome to. Otherwise, I can read it out for you. Okay, I'm going to read it out. And she's asking, some of us are care partners to people we're not related to, but the assumption always seems to be that it's a family member. Are there additional barriers for us? Do you have any thoughts on this?
Wow, great question. Thank you. And thank you for providing care. And you're right. Sometimes that is our fault, or we jump to assume that this is a family member. And I think that's something we probably could even incorporate. Thank you for helping me think about this on the spot, because I think it's something we can incorporate in our training for our team members, because they will say things like, gosh, I'm really struggling in providing care to this patient in the hospital who has memory loss. I wish their family member were here, and so
Mm,
there's even that assumption. So I do think there probably are additional barriers because there hasn't been as much research. We've started to kind of refer to it as family/friend caregiver. So I think that we're making some efforts in the right direction to be more open and broad in who we're considering as a caregiver, and that doesn't always have to be somebody who's family. So I would say continue to make your voice heard, identify yourself in that role. It's fine to say, hey, I'm not related to them, but I care about them. They need help. Maybe you're the only one, maybe they're an individual who lives alone and they don't have family close, and you're the neighbor that's stepped in to do this. So,
Mhm.
or you're a longtime family friend of theirs. So we have more work to do in that area, and I'd love to hear others' thoughts on that. And I think some of that goes back to, if we're going to evaluate the program and we're going to gather demographics about who's participating in our training programs, what kind of caregiver are they identifying as? Do they identify as spousal or adult child, or as a friend of this individual? And we also know, I guess I can add, that just because someone might have a family member who could provide care doesn't mean that family member wants to or is able to provide care. So
Mhm.
just because this older individual might have an adult son, they may, one, not live close, or not, have their own struggles or challenges, or be estranged and not able to provide that care. And so we're grateful for those individuals who do step in. I think that's the other message I try to um, continue to share in our healthcare system, is we are not equipped, nor are most other formal care structures equipped to care for all the older adults who need it, not on an
Mhm.
ongoing basis, for sure. We have to have family members and friends stepping in to fill this role in 80 to 90% of the cases. If family caregivers and friends stepped away and said, I can't do this anymore, our formal structures could not pick up from that. So we have to, the formal structures are more there. Our healthcare systems, our long-term care settings are more there to provide some ancillary support to what these family and friend caregivers are doing day in and day out.
Mhm. Thank you so much. And I see Monique has also followed up and said there are many single older adults with no children or partners. I think these other kinds of care partners will increase. At least I hope so.
Yeah, I
So,
agree. Yes, yes. And I think just because somebody lives alone, we also try to be careful to not assume that they can't manage for themselves. They may be happy on their own and doing just fine, but
Mhm.
as folks age, they could be more vulnerable. They could be more susceptible. We certainly wouldn't want them to fall and us not be aware of that, and be able to support them in their home. So,
Mhm.
yeah, and I think there's been something interesting that's been happening in our communities here in this part of Virginia. I don't think it's unique to us, but it's just something I have experience with here, are these kind of block programs within neighborhoods where individuals will agree to kind of be a block captain, if you will. And that means all of the individuals on my block, or on my street, in my neighborhood, that might need help, know they can reach out to me, and I'll check in with them regularly too, especially if they don't have other family or individuals close by to help out.
Mhm. No, thank you for that. And I see some comments in the chat as well, talking about some contexts that are outside of the States. I'm curious if I know a lot of what we've talked about is sort of North American based or specific more to the United States. Would you have any comments or thoughts on sort of the applicability of what we're speaking about outside of the US or North American context, or if there's any sort of similarities or differences beyond the US in caregiving approaches?
I think I'd hesitate to say, because I have not really, my research has been, for good or for bad, kind of more focused here in the States. And I'm grateful for the opportunities that I've had here. I'd love to learn more from those of you that are on, and your colleagues who might be doing work in this area. So I guess I'd hesitate to kind of go too far with that. I do think there are some universal experiences across
Right.
caregivers, likely wherever they live. And again,
Right.
maybe that is around identity and what we call them, and some of the challenges they face in trying to get education about their loved one or access to resources. So I think that's about as far as I'd go, but I'm guessing there
Okay.
might be some of those universal kind of underpinnings regardless of where folks live.
Hmm. Hmm. Thank you for that. And if anyone here in the chat does have a bit more knowledge on that context outside of the US, feel free to ask some questions or put some comments in the chat. But thank you for expanding on that. And a bit based on what you said as well about the universality, I'm curious as well how the employment status comes into play here. So I'm wondering if you could expand just a bit on how employment status impacts caregiving responsibilities, and either what the benefits or challenges can be to having employment in addition to your caregiving responsibilities.
Okay, and thanks for asking about that, because that is something that I have been interested in for a while, and it kind of comes from the perspective of, all right, if I'm a family caregiver, friend caregiver, and I'm working full time, how do I juggle all that? Is it feasible? Do I have an employer or supervisor or company that I work for that understands that and supports that like they do with childcare?
Mm.
Do they have a similar type of support program for elder care if I am an employee? And so that's kind of the root of what my questions have been. And so often going back to asking demographics and learning more about who these family caregivers are, I will often ask if they're employed, part-time or full-time, or they're volunteering in their community, kind of what are their other roles and how are they managing to juggle all of these things? So because it is unfortunate when you hear an individual say, I had to step away from my job because they didn't give me the flexibility. I think that's much of what I'm hearing caregivers say. If I had a little bit more of a flexible job role where I didn't have to have necessarily an 8 to 5 role, I could come in a
Mm.
little later or work weekends or work from home, and flex my time a little bit, that would allow me to continue to provide care to the individual I'm providing care to in likely in that home setting, in that community setting, or even if you're supporting their care in another care setting like assisted living. So um, I think, from what we're hearing, some of the larger companies here in Virginia are understanding that issue around elder care. I'm proud to say our healthcare system does, because we cannot afford to have for example, a nurse leave his or her role in our hospital because they can't manage that professional role and their personal role of caring for a loved one at home.
Mm.
And we have it happen. I mean, it happens. And so and there's only so much flexibility you can give to a staff member like that. They can't work from home in those cases, right? They're providing direct care to patients in this kind of care setting. So what can we do to be more flexible with their
Mhm.
schedule and understanding? And so a couple of things that we've done here, encouraging, and this would apply probably regardless of the company, encouraging folks who are employed and are also caregiving at home to reach out to their HR, human resources, employee benefits teams to find out what kind of additional services and supports are provided. We have a partnership with our healthcare system with a third party care company.
Mm.
So, if I'm working here and I need to provide care for my relative and I need help with that, and I don't know where to start with what agency might be able to come in and provide care to my loved ones so that I can continue to work here, we now have a third party that can help our team members do that. And we actually do that here in our office for our own team members. I sit in a center, a gerontology center here within our healthcare system. So not only are we taking care of our older community members here in the state, but our own team members who are providing care and getting them connected with resources. So more and more companies, at least here in the US, are creating what are called ERGs, employee resource groups. And so we are just launching a brand new one next month. I'm very excited about this. It's something I've been advocating for several years. It's an employee resource group for what we call double duty caregivers. So those
Mm.
are double duty caregivers, and that is a Canadian coin term, that you are working in healthcare, and you're also providing personal care. And so you're double duty. You're kind of never off the clock.
Mm.
Um, and especially if you have those clinical skills in healthcare, we found those individuals say, well, my family member assumes I'm going to provide care for them because I'm already in this field of healthcare.
Mm.
And so they're never really off the clock.
Mm.
And so those are particularly individuals we want to pay attention to, that they don't feel that they have to make a decision of one or the other. And is there some way that they can manage both?
Mhm.
And so I'm very excited about this upcoming launch of this employee resource group for our own team members who are providing care so that we can get them into support groups, which we might offer here through our healthcare system. There's some neat book clubs that are launching, and these training programs. So, and I think often what we found here is at least 20% of our workforce are providing elder care
Mm.
outside of their professional role here in our healthcare system. So that might be something for individuals to think about, what is the prevalence of folks who are working caregivers in a particular organization or agency, because there's power behind those numbers. And so there's 10,000 employees in our healthcare system. So to say that 2,000 or more are providing care, we
Significant.
can't afford to
Yeah.
lose those 2,000. And what do we need to do to reach out to them and the others we probably don't even know about, who maybe
Mhm.
haven't identified in that role, or aren't there yet, but are likely going to be there, based on aging relatives that they may need to step in and support. So
Mhm.
um, I think I recently read that it is as many as 2/3 of individuals who are providing care to an older individual are also working full time. And then there's many more who are still probably working part time. So, as companies need to pay attention to this. And so that's kind of been one of my advocacy roles here, at least within our setting, is to continue to inform our human resources and benefits offices about the prevalence of this among our team members and how they're valuable, and we don't want them to have to choose. We respect if they need to, but what can we do to provide more infrastructure here for them so
Mhm.
that they can manage both of these roles?
Thank you so much. And another question from our chat here from Ralph. Ralph, if you are here and want to unmute, you're welcome to. Otherwise, I will read your question out loud. Okay, Ralph is asking, during COVID, we noted the significant amount of care that was being delivered in facilities by informed caregivers. Did you see this as well?
Absolutely, except that um, there were some policies that were in the US, and maybe some were specific to Virginia, but I think more US through our Center for Medicaid and Medicare Services about who could visit during times of COVID to reduce risk of exposure. And so there were, and that was something interesting our office was trying to do in advocating for family caregivers. There were some cases where they felt they were being excluded from
Mhm.
being in their loved one's care setting. And they were willing to come and help. But there were some regulations, at least there for a while, very strict screening procedures, temperature being taken, using a mask at the minute you walk in. So as I reflect back on this, our team members who were, providing that direct care needed the additional support, and some of them were very sick with COVID, right? So we would be strained in terms of not having all of our full staff on board. But there were also times where there were required restrictions, not by our healthcare system. This was above that, required restrictions about who could come in.
Mhm.
Um, and then there were some policies that were kind of loosened or recognized that we can't do this without family members, and the residents in these care settings need to see their family members, and not just through the window outside. I mean, we have images of folks visiting outside the window because they weren't allowed in. So I think, you all have likely heard, and they're just going to continue to be likely long-term, ramifications from some of those separations and from some of the impacts cognitively even of having COVID and having long COVID. Um, so I guess yes and no. I know there were many more family members who were just anxious to be a part of their loved one's care.
Mhm.
But if they were in some of these structured care settings, there were times where there were regulations that prevented them from being on site, and but we needed them. So, it's unfortunate that that kind of mixed message was sent at that time. I think it made it particularly challenging. And again, I think there were some additional policies that kind of changed that said, they may need some additional training to come in or understand the process during COVID to come into this care setting,
Mhm.
but to prevent them was, really unfortunate.
Mhm. I'm seeing a lot of comments as well in the chat and in discussing with each other. So please continue to do that. That's excellent to see. I'm curious as well. There's some comments about the discussion around the cost of providing training resources and what we can do to help supply tools and training opportunities at a lower cost for maybe some communities that just simply don't have the resources to be providing training opportunities for for caregivers or family caregivers. Do you have any comments on sort of the costs associated with providing training tools and maybe some tips for how to have some low cost strategies in ensuring that training resources are available in their community?
Okay, so the most of the trainings that we've created, and especially these series of micro learning lessons, were funded through federal funders here
Okay.
within the US. And so that's good because we had grants and we could write in, this is what we believe the expense is going to be. And then our pledge to the funder and their expectation was that this would then be made publicly accessible and at no fee. So, so that's why I'm happy to make sure that you all can access and check out some of these lessons if you think they would be of benefit to you in your settings and with the caregivers that you work with. So it was kind of for us on the front end, like, what does it cost to create these microlearning lessons?
Hmm.
And if you use animation to convey a technique versus actors and real persons, and you're filming those. And so the second of those is more expensive typically because you're needing to use a studio and we're filming. And so I don't know that I could quote real specifically, but I think our package of the 52 lessons for the nursing home staff may have spent 75 to $100,000 to get that all together and packaged and on a platform, which was not initially YouTube, but on a different platform where we could pass this through to these workers in our different nursing homes here in the Commonwealth of Virginia. And so again, it does depend on how many lessons are in your package, at least talking about the expense of microlearning and the filming piece. I will say that we've developed a great relationship with several filming studios that have actors. And what we've been able to go in and do, which I never would have thought would have been kind of a side benefit of this work, is go educate these actors. These are not people who know dementia or know memory care or even in some cases have ever cared for another
Hmm.
individual. And so we were able to go in and educate these actors. Of course, we want to work with families who are in the midst of this too and hear their stories, but that wasn't always available to us. And so having actors who were hungry to learn more and did a fabulous job. So with the Caring for You Mind, Body, and Soul 10 lesson series for individuals caring for a loved one with memory loss, these actors portrayed that they were different characters attending a support group, a caregiver support group. And then the 10 lessons walk them through their experiences as they share that. It's almost like a mini series on TV, and they share
Right.
and open up about their experiences. And so we evaluated them at the end of this and about how much they learned as actors to be a part of this. So, I think the other thing you can probably do to trim your costs, not only finding out about other programs that already exist, and using those that are in the public domain is, do you need to use a professional to
Mhm.
deliver the training if it needs to be done in person or face to face, or are there volunteers that can be trained that are willing to do this and then not have an additional fee or expense to pass on to the agency that might be delivering this? So with the Dealing with Dementia workshop, the 4-hour in-person workshop that several of my colleagues and I are certified to deliver through the Rosalind Carter Institute, we don't charge our uh, attendees to come. There is a very impressive and in-depth 300 and some page manual that we order and we assume the expense for from the Rosalind Carter Institute and then pass that on to these individuals. So we try to be very careful about charging little, if any, for
Mhm.
a number of these programs to make them, widely accessible. And then again, we're thinking about who's going to deliver the training and what are the expenses for us to keep up our certifications, for example. And most of those are pretty modest, several $100s a year, for example. And sometimes we can write that into a grant fund to help cover the cost of us staying certified, getting certified, continuing to deliver these trainings. So um, if if we can make the trainings at essentially no cost to the caregivers that we're trying to reach, typically for us, that's been pretty attractive.
Mhm.
Sometimes you run the risk if you offer something that's no charge that folks might sign up and then not show up. They don't,
Right.
as we say, they don't have anything invested in it. But we generally have not had that experience because the way we're able to promote the programs hopefully resonates and they feel they have been, they're going to miss out if they don't participate. And so um, and again, we do a lot with promotion, we do a lot with reminders, and sometimes we have to limit them, but due to capacity and due to interest. But we also try to make sure it's a very worthwhile experience for individuals. If they're going to take their time away from their loved one, well, can we help you manage the care for your loved one and put some other programs in
Mhm.
place so you can come out to this program or so that you can participate in the quiet of your home. We
Mhm.
want to make sure that it's very valuable and worthwhile to you. And I think that's another, kind of universal theme we're hearing from many caregivers is, they're really just hungry and craving for more education, to not only understand what their person they're caring for is going through, but how they can continue to be supportive to them and hopefully take care of themselves in the process too.
Mhm. Thank you for that. And I think, we've talked a lot about today about not only the desire that caregivers have to extend their knowledge, but also on the invisibility of caregiving and more generally. As we're closely coming to the close of our time here, I guess I have a couple last questions for you. I want to loop back to the idea of the invisible army that you talked about earlier and how caregivers are often overlooked, and in particular, family caregivers. Could you speak a bit to more about bit about how this invisibility plays out, and as we work to increase resources and training opportunities, how we would measure the success of these programs and how we would conceptualize increasing their invisibility or knowing that that has occurred?
Yeah, and I'd love to. I don't know if there's a tool out there or we can create one or some measurement instruments that would help us know that, again, I shared with you earlier, like I feel like the term caregiving has kind of risen. It's gotten
Mhm.
this national and international recognition, and I'm grateful for that. But that's kind of more a gut feeling. I don't know that everybody would agree with that, or that if you asked, a family caregiver or a friend caregiver, they may just say, I'm so busy, I didn't have time to notice that. So we really do have to kind of meet people where they are. And again, I think some of it goes back to the identity, but you're right. There's been this concept for a while that individuals who are providing care, especially to older relatives, are really kind of invisible. And I think part of that has come from that we tend to be, and especially here in healthcare, the family caregiver or friend caregiver may not be the patient, right? It's likely the person they're caring for that's the patient. So the while the caregiver probably has really valuable information to provide if they bring their loved one to a appointment with the physician or have to come to the emergency room or to the hospital, that caregiver's providing probably really valuable background context of what's going on. They're not the patient.
Mm.
And so I think, the patient or the older adult or the person who is needing some care has been our focus. And while there's nothing wrong with that, and that makes sense, I think it goes back to this family centered
Mhm.
approach that there is likely someone else in here that is a part of the story, and not only a part, but a key part of
Mhm.
the story. So when we do training, and I shared that it's mandatory, at least right now for our hospital staff, thousands of hospital staff here, it's mandatory that they go through 2 series of training around memory care for our patients. I emphasize in this training again and again that it isn't just the patient that you're taking care of. It is the
Mhm.
person who is there with them, that family member, friend, neighbor. And if you don't answer their questions,
Mhm.
and help them along the way, that this patient is going to be back in as a patient again because the caregiver cannot continue to manage for them. We didn't get them the resources that they needed. So it really is, I continue to say, I say this to caregivers, I say this to our team members in healthcare, that the caregiver is a part of the healthcare team.
Mhm.
They may have different skills, but they probably have the most important skills and the best knowledge about the person that they're caring for, that we have to view them as a part of the care team. So maybe that's going to help reduce a little bit of this kind of invisible army kind of concept. Um, and I think also encouraging caregivers themselves advocate and use your
Mhm.
voice. Again, we talked about the numbers. There are 56 million caregivers in the US, we estimate, who are caring for somebody who's over the age of 50. So there's power in those numbers, and use your voice and advocate. And again, tell your doctor that you are
Yeah.
providing care, and make it known. It's a good thing. It's not a bad thing. It's not easy, and so we want to know about it so we can be helpful to you and get you connected with the resources. We don't want folks to ever feel like they're alone, and we hear
Mhm.
that often. They feel isolated. They can't get out to programs. They miss their own doctor's appointments and sacrifice their own well-being because they're so committed and dedicated to providing care for somebody. And while we're grateful for that, we want to take care of you too as a
Mhm.
caregiver. And so again, I think as many, whatever term we want to refer to, but one way we seem to be moving the needle a little bit is by saying to this caregiver, you are a part of the care team with us, and you're a key part of that. It isn't just the doctor over here taking care of your loved one, but we need you here and to be a part of this and to help you shore up your resources because you're continuing to do it on a day in and day out basis.
Mhm.
So we still have a way to go, but I think we're getting there. And I don't know, in the second part of your question, how to know. I feel like we're
Mhm.
making progress. I think there's more visibility, and I'm grateful for that. So we're heading in the right direction.
That's good to end on an optimistic note. And Jane, I can see you nodding your head there as well. So it sounds like we have maybe some agreement in the audience. If you have any comments, Jane, you're welcome to add them in the chat here before we end. But we are coming to a close of our Global Cafe, and I would love to hear sort of your larger takeaway messages for our audience and your takeaway thoughts of the day. But just to give you a moment to gather your thoughts, we'll first introduce next week's guest and topic. So please welcome next week Dr. Paula Rashan on understanding the needs to prevent prescribing cascades amongst older adults. So we're very excited for that conversation as well. So please stay tuned and join us next week if that's something that interests you as well. But now back to you, Dr. Kristen Jensen. Could you share your key takeaway messages for our audience here today?
Well, I appreciate the opportunity to speak about caregivers, and I'm grateful for all of you all for being a part of this today, and um, for being interested in, this person-centered and family-centered training. We're still kind of on the early phases. I've been doing it for several years, so I appreciate your interest in it and the opportunity to share a little bit more about it. I think I'm optimistic, and each time I hear a caregiver share their story, I really try to pay attention and validate their experiences and use those stories to improve the programs that we're delivering. So, each time I get to reflect back on these things, it just really makes me proud of our work and that this is kind of the right field for us to be in. So, thank
Mhm.
you all.
No, thank you so much. And thank you for all the work that you do and for being so generous with your time here today. I think we've all learned a bit more about what the status of caregiving is. So thank you for joining us. And thank you all for attending. And a special thank you to Luana, who helped us out here at the IFA. But we hope to see as many of you next week as we can. So stay tuned and enjoy your weekend.